Well, good afternoon, everybody. I'm Scott Eliason. I'm the correctional psychiatrist in town. I mean, there's more than just one of me, but I've been working out at the prison now for 12 years. And today I thought that I'd talk to you about psychosis. And really, I mean, psychosis, as far as a title of a subject, I mean, we could talk for a lot longer than just an hour in a grand rounds, right? It's almost like having a grand rounds on cough and will possibly cause cough. But, you know, it's a very broad topic, but we're going to kind of really focus on the thought disorders, like schizophrenia primarily, but also the more brief versions of that. And just wanted to start off talking about a case that I've got that was just showed a lot of aspects of psychosis and schizophrenia. It's a 36-year-old male that I've been treating for the last 12 years, the whole time I've been out there, and very psychotic and manic at the same time. And when he gets sick, he's both really aggressive and super hypersexual. Like, I remember he wouldn't come to clinic to see us, and we'd go to his cell and he would just stare at everybody's crotch and be dancing and jumping and yelling all sorts of sexual things. It didn't matter if you were a man, woman, anything. And he was just so inappropriate hypersexually. And so he refused to take medications. And so we got him committed, put him on an injection of Haldol deck, and we had to kind of march up on the dose, but he did really well on that until he developed neuroleptic malignant syndrome. And that, you know, can be one of the things that can kill patients. And he had a very, very atypical version of neuroleptic malignant syndrome. Jared, everything okay, man? We good? Thumbs up, everybody. Can you guys hear me? Yeah, okay.
Hey, sorry, I was just going to see if we could turn up the sound a little bit.
That's okay. Can you hear me all right?
Yeah, we can hear.
Okay. You know, these Zoom presentations, just like you're talking to a vacuum. It's so silent. But then over the years, he had 2 episodes of NMS, and they were very atypical presentations. All he would do is he'd get this altered mental status that was different than his typical hypersexual and aggressive presentation. And then we would check his vital signs, and he just had the tiniest fever. And usually with NMS, you get a pretty big fever. And so both times we'd send him to the ER, and they'd check his CPK, and it would be super high through the roof. So they knew it was NMS. But that can be really dangerous. And the way you avoid that is you move to a more atypical medication, you know, something that's less likely to cause NMS. And so over the years, moving him to an atypical, and we tried to keep the dose as low as possible. He then developed psychogenic polydipsia. So on one hand, we would be killing him with the medication. You know, too much medication was causing neuroleptic malignant syndrome. And on the other hand, if we didn't medicate enough, he was drinking water to the point where he almost died. In fact, he had a couple episodes of polydipsia, and the last time he had it, his sodium dropped to 108, and the hospital called me, and they said they thought he was brain dead and that he wasn't going to live. And miraculously, he came back. And so then what we did was we added Ativan and propranolol to his medium dose Zyprexa, and that seems to have balanced him out, and he's been stable for the last couple of years. But, you know, psychosis can throw all sorts of different tricks at you. And the seesaw was this balancing act that we were doing where too much medicine could kill them and too little medication could also kill them. So, you know, as psychiatric providers, you guys are the arbiters of normal human behavior. You get to decide and judge your patients on whether or not they are normal, you know, whatever that word normal means, right? But that's part of your job, is to decide, is this normal behavior or is this psychopathology that we're seeing? And a lot of times normal behavior can be taken as psychotic behavior if you don't really know what you're looking at. You know, like different levels of religiosity can be normal or it can be abnormal. Paranoia. I had a patient at Harborview who was arrested with a lot of child porn on his computer, and they brought him to the hospital because he was suicidal, and he told us that he was really paranoid that the FBI was going to come and take him off the unit. And I said, look, they committed you to the hospital. They can't just take you without like a court order or some kind of, or us discharging you to them. So don't worry about it right now. And then a half hour later, as the FBI was dragging him off the unit, I yelled down the hallway, oh, I guess I was wrong. So paranoia can often be just a normal reaction to a really bad situation that you're in. Anger, you know, anger can be psychotic. It can just be rational anger. Other cultures, you know, have beliefs that we might think are completely bizarre, but in that culture, they could be very normal. And then another thing that, you know, that we all deal with really, but in the prison, we deal with a lot is malingering. You know, a lot of times that can look like psychosis. And I say just flat out lying as well, because sometimes, you know, it's hard to tell what the secondary gains can be and why somebody's lying about being psychotic, but that can also be taken for psychosis.
Can I ask a quick question, or should I?
Please. Hey, it's so nice to hear from someone.
Hi.
Hey.
Hi, Scott. So I have a patient in the nursing home, cerebral palsy, a lot of anger, anxiety, angry. She's in the nursing home, not with her mother. Then for 5 days, she refused to eat and drink and refused to take her seizure meds. So the physician puts her on a hold, sends her to the emergency department. The designated examiner sees and drops the hold, which I'm surprised. So she goes back to the nursing home. Again, she throws herself on the floor. She's sent to a different emergency room. And there the psychiatrist diagnoses her with major depression with psychosis. So to me, you know, not eating and drinking for 5 days, you know, literally, it's not like I'm just saying it. And not taking seizure meds is really serious. And she doesn't say anything. But to me, this could be considered as a loss of reality, you know?
Yeah. A dramatic change. It sounds like a real dramatic change. Correct. Too, from a baseline. Am I right?
Right. Yeah. Because now I'm trying to talk to the designated examiner and just explain how I think or we think. Anyway, thanks.
Yeah, definitely. And thank you for jumping in. In fact, please jump in. You know, if I didn't get through half my slides, but we had a great discussion, I would feel like this was a huge success. So thanks
well, then
a lot.
I have one more thing I mentioned in the text.
Yeah.
There is mention of acetazolamide for psychogenic polydipsia. So I don't know whether anybody has tried it, or I tried it in just one patient.
Yeah.
We were doing a lot of other things and the patient improved. So I don't know how much the medicine helped.
You know, I didn't read about acetazolamide, but we've used propanolol a lot. That's something that's helped us. But psychogenic polydipsia is really tricky to treat, you know, other than locking down the water.
Correct.
Right. Yeah. So this is basically the agenda for today. You know, we're going to go through psychosis, what it is, how to treat it, and then how to interact it. And then we'll go through just some nifty pearls that often show up on board tests. So, there's basically 5 domains of psychosis, right? And you want to have these, if you're a psychiatric provider, you just want to be able to rattle these off like it's, like it's just the fingers on your hand. But you got delusions, hallucinations, disorganized thinking, grossly disorganized behavior, and/or catatonia, and negative symptoms, right? We're going to kind of go through each one of those real quick. So a delusion, right? It's a fixed false belief, right? You can't argue away a delusion. I can't tell you how many times in my residency at Sacred Heart, I would get so frustrated with the delusional patient because they'd be arguing with me about something and I would be proving to them, how that was impossible. And it just wouldn't get through. And I'd be so frustrated. And then my attending leaned over and says, Scott, it's because it's a delusion, right? The definition is fixed false belief. You can't argue it away with logic. And I thought this was a great picture that they had in Kaplan and Savick. They had this guy who believed that if he wore suits that were too big for him, it would make him appear taller. And they called that a delusion. I thought that was pretty funny because, how many times have I worn some kind of silly outfit because I think it makes me look better or whatever, But I thought that wasn't the best example of a delusion. But, you have bizarre versus non-bizarre. People always talk about that. And I think it, sometimes it can kind of be the eye of the beholder, whether or not you think a delusion is bizarre. But here's some examples of ones that I've ran into in the prison. And after I go through these, you guys think about ones that you've ran into, and I'm sure we'd love to hear the different stories that we've ran into. So guards are poisoning me, right? That's a good non-bizarre delusion. Feces are coming out of the pipes. A lot of times in prison, they flush shirts and different things down the toilet to then flood the whole tier with feces and urine and whatever's coming out of that toilet. But sometimes all those pipes are interconnected, and the guys learn how to sometimes get stuff to back up in somebody else's sink and somebody else's toilet. And so that one was a little confusing whether or not I thought that was bizarre or not. But torture machines sending waves from the basement, I thought that one was bizarre. Then I had one patient who thought his wife worked for the state police. And I was like, well, that's totally possible, until he said, and she comes into my cell and rapes me every night. And then I was like, well, that's less possible. And then a patient said that his body was just riddled with tumors, even though he's had multiple big workups and had no signs of cancer.
That was one of mine.
Who was that?
Sorry, Scott, this is Emily. I was like, that was one of mine, I think.
Yeah. Yep. Emily, we share people, but hey, good to hear you, Emily.
Yep. Hey.
I just recently, we committed a patient who had this belief that God wanted him to molest children. And he was a very religious guy, could quote all sorts of different stories from the Bible and how we all misunderstood the Bible because all these stories were actually sexual stories. And it was really interesting during the commitment hearing the next day when he was arguing that he didn't need to be committed. I just kind of quoted what he said the day before, that God wanted him to molest children. And he looked at the commitment committee and he says, well, he's got me there. No argument. He knew I had him. And I had a patient who believed there was a microphone in his throat so that the government could hear everything he did, including hear him poop. And he was so angry, he thought, what an invasion of privacy that while I'm sitting there grunting, the people want to listen to this. He was so angry about that. And I remember being like, no, nobody wants to listen to that. And he, just wasn't hearing me about that. And then this is a pretty common delusion you run into prison, is that prison gangs are out to kill a person because they ratted on them. And it can be, that one can be really tough to tell. Is this a delusion or is this just, fear for your safety? Anybody else got one?
Yeah, Dr. Eliason, I got a couple for you.
Yeah,
One of them, like the last one you were talking about, I see this a lot of times with people who've like used a lot of methamphetamine, but have you heard the phrase group stalking before? You heard that?
No, tell us about it.
Yeah, so it's like they believe that there's like a specific group of people who are like out to get them and like follow them around and like all this stuff. And I had a couple folks who'd moved like 10 to 15 times to try to get away from these people, but the group stalkers kept following them everywhere they went. And then about your arguing with delusions, I had a couple interesting cases at, I think UW actually, where we ended up diagnosing with delusional disorder, but the two of them were kind of interesting. One of them was a lady who had tongue cancer that had been resected at one point, and she had this like persistent delusion about the fact that the cancer was caused by like a laser beam being beamed at her from space, and that was causing all these other health problems. And so all of her like complications from chemo and stuff like that, she was like convinced were from that. Could not be convinced otherwise that like, hey, like maybe it's the chemo meds. There's like no chance that it was that. It was definitely the space laser.
Laser.
Yeah, that was a good one. And then I actually had a NP and nurse get really mad at me for not arguing with a patient who had a delusion because they said that I was perpetuating the delusion.
Yeah.
So this was on the cardiac ICU. There was a patient who believed that there were people sneaking into his attic every day and dripping acid down onto his legs. So he had diabetic neuropathy, but his explanation for why he had this like numbness and neuropathic pain was that people were sneaking in upstairs and dripping acid down onto his legs. And he worked for like Microsoft or something. So he was like pretty smart, pretty well off, lived by himself. He had bought like a $10,000 camera system and set it up all over his property to try and catch them, and then had all these like complex explanations for how they were evading the security, like they were like turning it off for certain times or like overwriting the footage and like all this stuff.
Yeah.
And it was like clearly a delusion. So I was just like, okay, all right. And they like really wanted to put him on like some kind of antipsychotic, which I was like kind of opposed to because he's literally in the cardiac ICU. And I was like, and they got really mad at me. Like I had them like have to call one of their attendings down so I could explain that we don't usually like argue with people's delusions, especially like in an acute setting like that for exactly the reasons you said. I'm like, we're going to just completely like, destroy the like patient provider relationship by doing this. He's not going to trust us anymore. And at the end of the day, he's going to still believe it either way. So anyway, I have a couple like really interesting examples, I think.
Yeah, that's great. I love that example too. Well, first, I love group stalking because I totally have patients that gangs are always, out to get them. I like that term. And then arguing with the nurse or the nurse wanting you to argue with the patient. It's really interesting because to these patients, this is really happening. I mean, somebody's dripping acid on that guy's leg, and then you're going to go and tell him it's all in his head. I mean, that could be so invalidating. I do see where people are coming from. They want us to be going there and like lay down the law and tell people that they're crazy or something. But, if you really believe these thoughts, that can really make them either, number one, openly fight you, or number two, put in their back of their mind that, okay, so you're part of the problem, and then add you in. It's hard enough to stay out of some of the delusions, if you don't join.
I totally agree, but I wanted to share another case where
please.
An elderly with delusions of infestation, parasitosis, and we told her that I know that you feel that this is real. I just wanted you to know that I feel that there is a part of your brain that's misfiring, and it creates these experiences that you will feel are real. If I had the same problem, I would feel it's real, and I would not believe anyone. And when I give this medicine, I was giving her antipsychotic, and she was willing to take it. I'm just trying to address that part of the brain. So if there's any way you can sort of just remind yourself that this is the brain network firing, it may help.
I really like that, because we've got to plant that seed of doubt to grow into the plant of insight. You know, we want the patient to develop that. Why else would they take some sort of medication from us, you know? Yeah, that can be really important. Thanks, Avalanche. What comes after delusions? Who remembers?
Hold on one sec.
Yeah.
Dr. Leslie,
Yeah.
can I ask a question?
Please.
So what do you think of what might be called social delusions? Like there's microchips in my vaccine that are tracking me, or this election was stolen.
You know, okay, so you know, I actually believe all those things. So just kidding, just kidding. You know, I think that when you look at cultures, that's really what you're talking about. There's a lot of cultures that believe things that we might not believe, and those cultures could be right here next door neighbors to us. And I think there's so many people that believe in a lot of those things that that, you know, we don't think, we see that there is enough evidence in reality that those are not true. That would just be normal, a normal variant with the subculture, I think.
Yeah, Dr. Eliason, when I've seen the definition of delusion before, I've seen it sometimes as a fixed, false, idiosyncratic belief, and which is interesting, because then after there's like some number of people who believe something where it goes from being a delusion to like what you were saying, more of like cultural belief. But yeah, I've seen that sometimes.
I like that. So that idiosyncratic kind of means that in their healthy mind, this would have never made sense to them. So
it's kind of like, it's like unique to that person is like
okay.
sort of what I'm getting at, I think.
Okay. Well, good. Thanks, guys. All right. And then hallucinations, right? Hallucinations are I think, really tricky to tease apart because they're so subjective to the person. You know, it's just, do they tell you they're experiencing them or not? I mean, you can sometimes see somebody, you know, actively responding to internal stim or actively, you know, grabbing at things in the air, right? But most of the time, it's just somebody reporting. But it's an actual perception. So their eyes, their five senses are actually receiving some sort of input that they believe is there, but there's no external stimulus, right? It's vivid and clear. A lot of times you'll get, you know, this is not a malingering lecture, but a lot of times in malingering, you'll get these really vague things like, I hear mumbling, but I don't know what they're saying, or I see little shadows going past and stuff. But typically hallucinations are clear and vivid. It can be any sensory modality, any of the five senses. And usually, you know, the voice, if you're hearing voices, it's very clear they're not your own thoughts. Because I think a lot of times people describe their own negative thoughts as a voice, but true hallucinations are very distinct from a thought. And then it doesn't count when you're falling asleep or waking up, right? Those are called hypnagogic and hypnopompic hallucinations, and those are just normal phenomena. And the way I remember that, you know, patients, especially patients who are drug seeking for more medicines, they love it when they have one of these and they come and they tell you, oh my gosh, I had this thing last night and I need more meds. But I remember a hypnopompic is like you're popping awake, right? That's, and then hypnagogic is the other one. Disorganized thinking, right? That can be either very mild and hard to kind of detect, all the way to it's just so severe you can't even communicate your needs at all. We recently committed a guy out at the prison who, when he's on medications, he still looks pretty sick, but when he's off medications, he can't even communicate any kind of need or any kind of thought because he gets so disorganized. But I just put a couple different examples on here of, you know, clanging when they rhyme, like I fell down the well, cell, bell, you know, and then neologisms when they just start throwing out strange new words. A lot of times I just can think, oh, Scott, you're not that smart. So they're using some fancy word that you've never heard of before, right? But when somebody's like real delusional and real disorganized, and then they start throwing out these big words that you're like, wow, man, I went to college, but I did not get more knowledge. You know, it's probably a neologism, and it's can be really fun and interesting, I think, when they're throwing those out to then clarify with the person and get those words down if you can. But they can be really interesting. Grossly disorganized or abnormal motor behavior, right? So it can be some childish or silly behavior or some real aggressive or agitated behavior. So there's this one patient out at Max who always puts underwear on his head. And I was telling him, why don't you wear the little like ski cap that all the inmates are issued? And he always has some kind of reason, but it's all just, you know, silly. And then there was another patient who I was seeing in clinic, and he was sitting on the table, totally calm. He's sitting probably like 4 feet away from me. And then there's an officer standing probably 2 feet away from him, you know, watching him. And this patient is calm. We have the whole appointment. Everything seems fine. And I say, okay, well, I guess I'll see you later. And with no warning, he just dives on the officer and it just starts pounding on his face. And they roll to the ground, and the nurse runs over and starts trying to pull him off. And my reaction is, ugh! And I just kind of like stayed there. And after a couple minutes, I went over and I said, oh, maybe I'll help out. But not very helpful. But that's a good example of grossly disorganized, unpredictable aggression. Like there was no sign any of that was coming. And all of a sudden, he just attacked this officer who didn't do anything. You can sometimes, I mean, it's real easy to see that somebody is not doing well mentally when they're smearing feces, naked, dancing around, you know, not in an appropriate place for dancing. And also sometimes you'll see people just posturing, and they'll hold some kind of pose, some kind of awkward pose for a long period of time. Anybody else have any good examples they've seen of grossly disorganized behavior that didn't seem to have any good rational reasoning behind it? Well, if you think of one, pop in.
I don't have an example, but I was struggling with that same patient who refused to eat and drink and refused to take seizure meds. Means she's not talking, so I don't know whether she's delusional, whether she has hallucinations. Then she's not talking, so I can't comment on disorganized speech. Then can I say that this is grossly disorganized behavior? Because by criteria, I have to have one to say this is psychosis, you know?
Yeah, well, I mean, what you're describing, not eating and then just randomly throwing herself on the floor and screaming, I would say that meets grossly disorganized behavior. Sure.
Okay.
Yeah.
Right.
And then the other thing you could have is catatonia or abnormal motor behaviors. And, you know, catatonia, it's real dramatic when you see it, but it's this marked decrease in reactivity to your environment. So where you just stop really interacting with your environment in a lot of ways. But you can have negativism. That's when, you know, you try to move the part of their body and they'll actively, you know, they're just sitting there, but no questions very concretely, but oftentimes they'll stop any sort of spontaneous speech. Hey, Nari. Hey.
Hey, good to see you. This is a great lecture.
Hey, thanks.
It's really enjoyable.
You looked like you just turned on your camera like maybe you had something to say.
No, I don't want to interrupt you.
Okay. Well, good to see you. And then Stupor, you know, just sitting there looking like they're not interacting at all, but they're in just a fog. Negative symptoms. Anybody know who this is? Need extra credit. Not Debbie the actress.
Ethan says Debbie Downer.
Yeah, it's Debbie Downer. That's right. You win. Debbie Downer, wah, wah. A lot of times when you tell a layperson, oh, do they have negative symptoms? They're like, like Debbie Downer, like they're always real negative. But, negative symptoms, that almost looks like somebody with Parkinson's, right? Where they stop having a lot of emotional expression. They stop just being motivated to start doing things. So their spontaneous actions kind of stop. They start talking very little. They don't enjoy anything. They don't want to interact with other people. And this is really where a lot of the dysfunction from psychosis and schizophrenia comes, is from negative symptoms. So 5 domains. All right. Okay. If somebody in the classroom, unmute me, and I want somebody to tell me the 5 domains. In order. Anybody? Come on. You're still muted. Okay.
Yeah, we're unmuted now.
Okay, let's hear. Number 1. This is the 5 criteria for psychosis.
Oh.
It's the ones we just went through.
Delusions.
Hallucinations, disorganized speech, disorganized thinking, disorganized behavior, negative symptoms.
Yeah. Good job. That's gotta be you just gotta be able to just rattle it off and know those things, because the rest of your life you'll be dealing with that. So this is a really long, hard to pronounce word. I'm going to go for anosognosia, but it just really means lack of insight, right? And it's classic for people with psychotic disorders to not have insight into it. I mean, every once in a while you'll run into somebody who has insight into that at the beginning. A lot of times they develop insight after years of treatment, but at the beginning it's very rare. A lot of times, they're hearing this voice telling them to do something, and it means something to them, and this is real. It's lack of insight can be very common. So it can be really important when you're meeting with somebody to spend time with them, right? I said time is important. And what that means is, oftentimes people who lack insight, they might have developed enough insight to where they know, don't talk to the doctor about the FBI watching me, and how the government's in on it and they're all zombies, and just keep that under wraps, right? We saw this patient yesterday in clinic, and it was really interesting because the clinicians had told me he's doing really badly. We think he's cheeking his medications, so we want you to see him. So I pull him in, and it was like 5-10 minutes. He's doing great. He's like, I think I'm ready to get out of this unit. The meds are treating me great. No problems with them. And then after spending just a little more time, he kind of mentioned something about being related to Alexander the Great. And, a lot of people are into Ancestry.com. What do I know? Maybe he did find out he's related to Alexander the Great. But then I said, how'd you find out you're related to him? And then he said something about, well, his dad was from El Salvador, and the family has a castle down there, and his mom is from Greece. And so I'm like, okay, well, I didn't get all that stuff about your dad, but your mom's from Greece. Maybe, yeah, my mom's from Greece, but actually my dad is really George Michael. And then I'm like, wait, George Michael, the singer? You mean like all you got to, or you really got to have faith? Or how does that song go? If I could, yeah.
Yeah, you got to have faith.
Hey, there.
Yeah.
Thank you, Allison.
Father figure.
Yesterday I nailed it, and I was singing. He's like, exactly. I love that song. My dad, he wrote that song, and then I'm like, oh, okay, you're not doing great. This is not going well. But that's first 10 minutes he held all those things under wraps. So really, spending time with them is really important because they lack that insight.
Hey, Scott.
So, yeah. Alice.
What about neurologic anosognosia? I sometimes tell the staff that this is not delusions. This is like when they have a paralysis on one side, or that they have Alzheimer's, and obviously they say they don't have any. I tell them this is not a delusion.
Yeah, yeah.
Or
Yeah. Well, I think, I think all of psychiatry, Alice, is actually neurology that we don't understand.
right,
Right. It's
right.
all these things are firing and making it up. But we know in neurology that you can have strokes in certain spots and develop, I'm going to try it again, anosognosia into your illnesses, so we know there's a neurological component to that. But I mean, I would go even further and say that a delusion, even though we call it delusional, it's also neurological on some level.
Right.
They're not making this up for fun, but their brain is misfiring in some way we don't understand. Delusional disorder, this can be really tricky. I mean, it's really fun to diagnose because it sounds like, hey, for once I didn't diagnose schizophrenia. Isn't that exciting, right? But it can be really hard to tease some of these little things away. But delusion disorder is supposed to be a delusion of a month or longer, and you don't meet criteria A for schizophrenia. And criteria A for schizophrenia is that you need 2 of the 5 domains. So delusions is just 1 of the 5 domains, right? So you don't have hallucinations, you don't have grossly disorganized behavior, the 5. But it's really interesting as you dig into the delusional disorder and read up on it, it'll say things like, or if there are hallucinations prevalent, it has to be really related to the delusion. So it starts breaking its own rules all the time. So this is kind of a confusing one, but in general, what you want to think is the person's functioning fairly normally, but they have this one fixed false delusion, right? And that's delusional disorder. They come up with this number of 1 out of 500 people have delusional disorder. Who knows how they come up with these numbers, but there's a real famous case with Jodie Foster, right? And Hinckley, right? That Hinckley believed they had this relationship. This is a note that he wrote to Jodie. He said, before he tried to assassinate Ronald Reagan to get her attention, he said, I love you 6 trillion times. I mean, that's a bit much, right? I mean, I want to be loved a lot, but not 6 trillion. That's crossing a line. Don't you maybe like me just a little bit? I think that part's kind of charming because you're like, he's another human, right? And then he says, this is just so great. You must admit I am different. And I just thought, wow, man, if you're Jodie Foster and you got this note, how do you not like this guy? Schizotypal personality disorder, right? This is a little different than schizophrenia because it's this pervasive way that you see the world that's long-standing. And as a personality disorder, it doesn't change. This is your baseline all the time. And you can have this discomfort and reduced capacity for close relationships. You get these cognitive and perceptual distortions, but not far enough to meet criteria for schizophrenia. You get really eccentric behaviors. And I think that, we all have ran into people outside of our professions that are just like a bit odd and have really strongly held beliefs that are past what the cultural norm is. Like, for example, healing crystals. It's not something I get into, right? Some of you guys might be into that, right? And I think that there's a culture where that's normal, that you believe in the crystals can heal you. But then let's say you take that a step farther where if anybody else has the crystals, they actually emanate this kind of negative energy to you. And so you can't dissociate with anybody who has any of those crystals. It's just a step further in those cultural norms. And it begins by early adulthood. And you have 5 or more of the following. And I thought that was interesting because you have to have a lot of these criteria. But ideas of reference, odd beliefs or magical thinking, the perceptual experiences, bodily illusions, odd thinking and speech, suspiciousness or paranoia, and inappropriate and constricted affect. So you have to have 5 of those. So you really can only miss 1. Right? Brief psychotic disorder. We're going to kind of cruise fast and furiously through these next couple of slides because you guys can just look this up in the DSM. But brief psychotic, right? That's a day to a month. Then you got schizophreniform. I put Fancy Nancy on here because if you want to impress any of your friends, just start talking about schizophreniform disorder and they'll be like, wow, you apparently know a lot. But schizophreniform is a month to 6 months. And then schizophrenia, that's when you make the jump to 6 months and beyond, right? Schizophrenia, you have to have 2 of the 5 of the domains for a month. So for a month, you have to be clearly psychotic, right? And then outside of that, you have to have this level of functioning that was significantly different from your baseline. And that disturbance lasts for 6 months, where for 6 months, all of a sudden, your straight A student is now failing out of classes, losing their job, you know, their functioning is severely impaired. And then you can have all these neurological soft signs that a lot of times board tests love these. We'll get into some of these later on, but there's all sorts of neurological signs that show that all these mental illnesses really are brain diseases that we just don't quite understand. The other thing that I'll say about schizophrenia is that it's really a grab bag, I think, of probably 100 or more different disorders. But, you know, we understand this so little that we created this box that we kind of lump a lot of people in together, but it's probably really a lot of different disorders. In schizophrenia, you know, one of the hallmark characteristics that's not a clinical criteria. So it's one of the cornerstones of schizophrenia, but it's not what DSM criteria is cognitive impairment, right? And that, you know, this impairment in executive functioning. It's really important. We'll come back to that a little bit. But cognitive impairment and negative symptoms are really what probably cause the most dysfunction, you know, loss of job, loss of relationships. Most of that stuff comes from those 2 things. And likely a lot of different causes. Oh, I talked about that. But there's this prodrome, right? That, you know, ever since I've been a psychiatrist, we've always been talking about trying to catch the prodrome and start to treat it. And maybe we can, you know, attenuate the actual disease. But there's this prodrome that a lot of times they say kids start to play a lot of video games, or, you know, college students, since that's the age when people start to develop schizophrenia, you know, playing video games and watching TV rather than getting out and socializing. But the problem is that then I'm looking around at kids these days, right? That's what everybody does all the time. And then COVID, Netflix, you know, I mean, that's like everybody. But, you know, that prodrome is when you start to see that functioning decline, really. And then a lot of times at first, as the disease progresses and they first start coming to help, it can look like they're malingering just because it hasn't like fully blossomed the disease. And so sometimes if you know, you can kind of be like, this looks really atypical. This doesn't look like classic schizophrenia. I think they're malingering, right? And this goes back to that patient that of mine, I'm calling him Mr. Cook, but he believed that his wife was coming in and raping him every night in the prison. And that was my first introduction to him. But he came into clinic and told me that. And I was like, okay, so probably really sick. And then he refused any of the antipsychotics I offered him. And then he said, but I will take Klonopin. And I thought, wait a minute, is this whole thing like just this kind of elaborate malingering ruse to get a benzo, right? And so he wouldn't take any antipsychotics. So I just put him down for a follow-up. Anyhow, he ended up getting transferred to the hospital unit at the maximum prison. And while he was there, we were watching him real closely, and it just didn't make a lot of sense. Sometimes he'd act really psychotic, and then other times he'd look really pretty normal. And then the psychologist, after about a month, he did some testing with him, and the patient scored as malingering. And then this patient came to the psychologist and said, I made it all up. I'm not actually sick. You know, it's just, I wanted to get transferred to this unit. And so we were like, oh, so he's malingering the whole time. But that's not the end of the story. This picture means that even a broken clock is right twice a day. So this patient, we discharged him from the unit. And then about a month later, the clinician at the yard called me and said, you know, you got to see this. We put this guy on watch and we've been videotaping him. And he's just standing in this corner, gesturing like this and talking to somebody for the last 3 hours. And I was like, what the heck? And so I'm convinced again. So I'm like, okay, put him back in the hospital. When he got to the hospital, he just started fighting everybody. Every meal they brought, every move he had, he would just attack. You know, the whole team had to get suited up with their shield and body armor and to go in and deal with him because he would just attack everybody. So we finally got him committed, got him on a shot of Haldol, and all of a sudden, this just all went away. And he was just the nicest guy. All the fighting, all the anger, everything went away. And he ended up getting out of prison and did just great. Didn't come back to prison, you know, which is kind of a rarity. So, you know, in the old DSM-4, we had all these different subtypes. This DSM-5 got rid of them. And the only thing that we really specify is whether or not it's with catatonia. But I'm just going to go through some terms real quick that you'll see in literature and history. I'm not even going to pretend I speak French or how to pronounce this one. Buffet de la Rente or something. Anybody? No? But I put French fries in there because I still call them freedom fries from Desert Storm. But the symptoms, basically, this is just a shorter period of time schizophrenia, so 3 months or less. And the French clinicians, they say that only 40% of these people actually go on to develop schizophrenia. So they think they've kind of identified a specific disorder that won't go on all the way. Then you have latent schizophrenia. It's basically mild schizophrenia, or what they call borderline. Then I don't know about you, but psychiatrists just never use the word borderline unless they're talking about borderline. You know what I mean? Because otherwise it sounds like I'm talking about the combination of schizophrenia and borderline. But it just means not full-blown schizophrenia, mild symptoms, not overt psychosis, but probably what you run into with some schizotypal and schizoid personalities. That's latent. And then they have this term oneroid. And oneroid schizophrenia is when you're in this dreamlike state. You're not fully oriented. It's almost like you're in a whole new world. Your delusions and hallucinations are overwhelming, where you stop being involved with the real world and you start being involved in this dream world. And usually, what do you want to think when people are, what do you want to be suspicious is going on when people have oneroid psychosis? What do you guys think? What should you suspect? Yeah, Alish.
Drugs.
Drugs, great. Yeah, that's top of the list. What else?
Catatonia, maybe.
Well, you would see catatonia whether or not it's there, right?
Epilepsy or something neurological.
Yeah, so basically other medical causes. Like oneroid schizophrenia, I think most of the time you got to be suspicious that it's a delirium of some sort, right? Either drugs or medical causes. Then paraphrenia. Paraphrenia is basically paranoid schizophrenia. But you'll see that term in the literature where you get these real crystallized and organized systematic delusions. And I'll go into one of those in just a minute. Oh,
I like the choices of your pictures.
Thank you. PowerPoint makes it easy these days. But let me just real quick, because we're basically out of time. Gosh, man, I did not get anywhere near where I wanted to. But I had this patient who he believed that the government had been replaced by aliens that were body snatching everybody. And then he went up to a pastor and just out of nowhere, had never met this pastor before, shoots him like 6 times, including in the head. Luckily, the pastor survives. The guy hops on a plane, flies to Washington, D.C., where he's arrested because he's at the White House throwing notes over the fence to Obama, letting Obama know that he knows about all the aliens. And that's a great example of this crystallized, organized, systematic delusion, right? Where it's really organized and there's a story and it's all crystallized in his mind. I was going to shoot through. I wanted to cover one more thing real quickly, is suicide and violence, right? A lot of times people with schizophrenia get a really bad rap because they always get blamed for being really violent. And so this picture right here that you see, that's the patient drew this picture. That's the alien body snatchers, what they look like if you can actually see them. But the truth is, right, because I always feel like there's a trick to schizophrenia and violence. The truth about violence is untreated schizophrenics are likely to be more violent. They aren't more likely to commit homicides than the general population, but they are more likely to be violent. And then if you take treated people with schizophrenia, they are more likely to be violent than the general population, but most of violence is perpetrated by people who don't have schizophrenia. So if you run into that, that's often a board type of a question. I guess we're kind of out of time, but any other questions or things that you guys wanted to talk before we ended?
Dr. Eliason, thank you. This is Nina Germain. I appreciate the lecture.
Hey,
I have a
Nina.
question about, hi, it's a pleasure.
Hey.
I'm just on telephone. Psychosis, in the emergency room, we always get, oh, you're hearing voices, therefore you're psychotic.
Yeah.
And that's the only thing that they look at. I think I've read before that about 15% of the world's population has heard voices, and that about 1% of the world's population is actually psychotic, which makes hearing voices pretty non-specific. You're more likely than not to not be crazy if you're hearing voices, statistically. That's just one that I've read. Have you run across any other figures in your research?
No, I don't know any figures to quote to you, but I mean, you're hitting a point that we all run into, where patients describe this nondescript report of hearing voices, and it can mean so many different things. And one of the things it can mean is I'm having auditory hallucinations, but I think there's a million different things that I'm hearing voices can actually mean, but it takes time and usually a relationship and different things to really know what that report actually means. And it's easy in the ER to be like, psychosis.